So good morning and welcome to the first virtual meeting of the Greater Manchester Joint Health Scrutiny Committee. This meeting is being live streamed to members of the public in line with the latest legislation enabling our meetings to take place virtually during the coronavirus pandemic. Apologies have been received from Councillor Stephen Homer and Councillor Eve Holt, who will hopefully be able to join us at 11 o'clock. We've also had apologies from Sophie Taylor. So I'd like to, item 2, the appointment of chair. I'd like to invite nominations from the committee to appoint the chair of the Joint Health Scrutiny Committee for the municipal year of 2020-21. Do I have any nominations?
Nominate John O'Brien, Councillor Ray Dutton.
And is that seconded?
Seconded, Councillor Stella Smith.
Thank you very much. So I'd like to invite Councillor John O'Brien to take the chair, please.
Thank you, members. We need to appoint a vice chair now. Do we have any nominations for vice chair? In that case, Ray, Councillor Dutton, would you be prepared to be vice chair?
I'm willing to take that on, John. Thank you for that nomination.
Are there any other nominations? Do we all agree with that then?
Agreed.
Thank you. Thanks, Ray. Right. John, do you want to do the membership?
Yes, Chair. This is just to note the membership for 2021. So we welcome Councillors Mark Cunningham from Bolton and Councillor Akhtar from Oldham. They've replaced Councillors Linda Thomas and Eddie Moores respectively. So on behalf of the committee, we would like to place on record the appreciation to both Councillor Thomas and Councillor Moores and welcome both of their replacements to the committee. Thank you, Chair.
Thank you. All right. Members are requested to complete and return their annual declaration of interest. Now, you do one for your own council, but the GM need one for legal reasons. So if you could complete that and email it back to Lindsay or Joanne, that'd be very helpful. Thank you. Now, you've all been sent the terms of reference, and I would hope that you can abide by that. Declaration of interest. Do we have any declarations, Joanne?
None received, Chair.
Thank you. Right, in that case, move to next item is Warren on the Manchester Test and Trace programme, please.
Sorry, Chair, are we doing the minutes from the last?
That might help, actually. You know, it's a Freudian slip. Can we approve the minutes from the last meeting, please?
Councillor Ray Dutton, approve.
Seconded. Go. All right. Sorry about that, John.
Chair.
Warren Heblett, please.
Thanks, Chair. I'm going to introduce Martin Pritchard, who's been the Senior Responsible Officer for the Greater Manchester Test and Trace programme from its inception, and what I'll do just before then is just orientate in terms of the agenda. So what we'll do, if it's okay with the committee, is that we've got a substantive item that updates the committee on a full range of work that's taken place as part of Greater Manchester's response to the COVID pandemic. Identify some of the key areas of work and signals some of the specific areas of work which are in view over the course of the coming months. And if we could move to the slide set and start with the update on test and trace, and I'll invite Martin Pritchard as the lead for that to start taking us through that, if that's okay.
Thank you, Warren, and thank you for inviting me, Chair. It's just best to check that you can both hear and see me before I carry on talking.
Yes, you're live, Martin. Thank you.
Thank you very much. So could we move to the next slide, please, for the person who's controlling the slides? Sorry for the poor person who's controlling the slides. What Warren's done is he's skipped us straight through to the test and trace slide, which I think is it's number 9 in the slide pack. Thank you very much. So good morning, everybody. I'm Martin Pritchard. I am the Accountable Officer of NHS Trafford, and most of us accountable officers have a lead role for something across Greater Manchester, and mine since May time has been the Test and Trace programme. You've received a paper. What I want to do is say things which are additional to the paper. I'm joined by my colleague Dave Bulger, who is much more expert than I am on the contact tracing part of this. So I'm going to talk about the testing part of this and then hand over to Dave to talk about the contact tracing part of this, and obviously happy to answer any or all of the questions that you've got. So in terms of the mass testing strategy, back in late April of this year in Greater Manchester, we developed a mass testing strategy for Greater Manchester in the absence at that time of a national testing strategy. And in that we set out 4 objectives for Greater Manchester. The first was to reduce the harm that was being done to people through COVID by testing. And if we recall, at that time, we were at the very height of the first wave of the pandemic. The second was to support the NHS and social services in reducing the harm to people who didn't have COVID, but were unable to access services normally through testing. The third was to support the restarting of the economy and normal life as best as possible by testing. And the fourth was to harness all the expertise across Greater Manchester to contribute to the national research project about this, recognising that this is a very new disease and every day we're still learning new things about it. It was very clear at that time that there were severe constraints on the amount of testing that was available. And what we did was we formed a mass testing expert group, which is co-chaired by Professors Peter Traynor and Ian Bruce. And we tasked that group to get together a group of experts across the virologists and immunologists and various clinicians and academics across Greater Manchester, and draw upon that great pool of knowledge to support us and to answer the question, who should we test and why, for what purpose? And they've done great work in looking at which cohorts of patients should be tested, the frequency of testing, the type of testing that's appropriate for that. And through that work, we've managed to implement an approach across all of Greater Manchester in terms of testing. And I'm sorry, I am going to have to use some management jargon in this, but I'll try to keep it as minimal as possible. So all of that work is largely focused about what we call Pillar 1 testing. Pillar 1 testing relates to the testing capacity we have within the NHS labs and Public Health England labs in Greater Manchester. During this time, nationally, the government, through the Department of Health and Social Care, developed a network of commercial labs known as the Lighthouse Labs, and this we refer to as the Pillar 2 testing. So this is where people are able to access or have been able to access an appointment through either phoning 119 or going through the central government website and booking themselves a test either through one of the regional testing sites or one of the mobile testing services. And as that capacity became increasingly on stream, again through the mass testing expert group, we worked together across Greater Manchester, and Bernie was on the call as part of this, part of the group, part of the process, asking ourselves questions such as what should be the frequency of testing in care homes, which other groups of people should we test, how should we test, provide tests for example, people with learning difficulties where there are a whole range of issues about consent. And through that, we've done our work. The other thing I just want to mention is to set out in the slides, which is the different tests that are on offer at the moment. So essentially, we've got 2 types of tests. One is a test to see essentially whether you have COVID or not, and these are the PCR or antigen tests. And then the other test is the test to see whether you've had it in the past, and these are the serology or antibody tests. So there are 2 different types of tests that are available at the moment. Move on to the second slide, please. So as I say, we've worked on this from April. We have, as I say, set out those programs of testing for patients to support that reduction of harm of patients and to support the restarting of the NHS. And we've also worked in particular over the last few weeks with the 5 universities and the College of Music and some of the independent universities across Greater Manchester to work together to prepare ourselves for the influx of students that are coming into Greater Manchester at the end of this month and towards next month, to make sure that we are well prepared as possible for this. Just at the bottom of the slide, I've said that we are working continuously with Department of Health and Social Care, because the Pillar 2 labs and the Pillar 2 capacity and testing, these are nationally organised and run services, and we are constantly on a daily basis liaising with them in terms of what we need in Greater Manchester to support local testing and where those things can be deployed. However, as I say, they are nationally organised and run services, and one of the constant conversations that we've had is the degree to which we should have control and the devolved powers in Greater Manchester to be able to direct some of that ourselves, versus the advantage of having national systems where things can be directed on a national basis. So I'm going to hand on to Dave. I know you'll have lots of questions, but if it's okay, Chair, can I just hand over to Dave to go through the contact tracing part of this and then take the questions at the end, if that's okay.
Totally agree, Martin. I would like members to hold off with the questions until we've finished the report. Thank you.
Thank you.
Thank you, Martin. Thank you, Chair, and good morning, committee. Ryan, could you move on to the first contact tracing slide, please, that one? So really just to set the scene, contact tracing in across the country and in Greater Manchester isn't new. I guess would be my starting point. It's a tried, tested and proven approach to managing infectious diseases and pandemics, and has been for centuries. So what we're attempting to do in relation to COVID-19 isn't new. Within this country, it's probably at unprecedented scale. So the national approach to contact tracing has 3 levels to it, 2 of which are delivered nationally and 1 of which is delivered locally at a Greater Manchester and locality level. Level 3 is what's described as national call handlers contracted from external providers. Now, these are the individuals who contact an individual who is identified as the contact of an index case. So if somebody tests positive, they identify who they've been in close contact with whilst they've been infectious. The level 3 national team then rings those people to advise them to self-isolate for a period of 14 days. Level 2 of the national model is what I described as professional contact tracers recruited through NHS providers, and they're responsible for the initial interview of the index case, so of the person who has contracted COVID and has been escalated to the national contact tracing system through the national testing arrangements. Level 1 is then the team that we've established within Greater Manchester, and that's responsible for what's described as complex contact tracing. So there are clearly some scenarios for which a national model isn't suitable, and that particularly relates to individuals or cohorts or settings that are defined as complex. So that could be a school, a university, a large workplace, a health and care setting such as a hospital or a general practice environment, but it could also be a cohort such as rough sleepers, sex workers, or it could be an individual who's got very specific needs such as a profound learning disability or a confirmed mental health diagnoses. And what the level 1 team is responsible for is leading on the contact tracing with those very complex settings, cohorts and individuals, managing any consequences. So clearly when we're dealing with very complex settings, sometimes there are consequences to the contact tracing episode. So for example, very topical at the moment in relation to schools, it can involve teachers and pupils being asked to self-isolate, and that has some implications for localities, communities, parents and those directly involved, but also supporting very vulnerable people and households. So some of those who we identify and request to self-isolate have a whole range of needs. And so the role of the level 1 team is to ensure that those needs are met. So Ryan, if you can move the slide on, please. So I'm going to say a little bit about the level 1 function in Greater Manchester, and then follow on with some observations on the national level 2 and 3 system and some of the steps that we're taking to address some of the current challenges that we experience. So I shan't talk through what is clearly a pretty complicated and convoluted diagram, but simply to say what this reflects is that we have a whole system approach to contact tracing at level 1 that involves a Greater Manchester hub staffed by a number of staff from a range of backgrounds. all 10 Greater Manchester localities, all Greater Manchester hospitals, and then other key partners such as Greater Manchester Police and Greater Manchester Fire and Rescue Service. And we work collectively to ensure that the right person is responding to the case, that consequences are managed, and that vulnerable individuals are supported. To give you some context about the scale of the operation, the GM Contact Tracing Hub went live on the 8th of June 2020, and as of 5 p.m. on Monday, so the 7th of September, the hub had escalated to 1,451 complex cases. 831 of those were in hospital settings, 620 were in other complex settings, such as the ones I mentioned earlier. Reflecting what is happening within the wider Greater Manchester community at present, what we have seen is a significant increase in recent weeks of the number of cases coming into the GM hub, and we've 110 cases in the past 6 days. They are spread across health and care settings, education settings, and then workplaces and businesses. What's very clear for us is over the past month, what we saw was a significant increase in the escalation of cases relating to workplaces and businesses, which tied with the wider reopening of the economy, and particularly around hospitality settings such as bars, cafes and restaurants, retail settings as they reopened and as people increasingly went back to those environments, but also factories and warehouses, and particularly those that are involved in food processing and distribution, and factories and warehouses linked to logistics and distribution, including sorting offices and delivery offices. What we've clearly seen as well, though, is that when we devote the time, energy and a whole system approach, we can be really successful in what we attempt to do. So as it mentions at the bottom there, we reached so far of all of those settings, 100% of settings that have been escalated to us. So every single setting that's been escalated to the Greater Manchester Level 1 contact tracing arrangements from the national team has been successfully reached by either the GM hub or by a locality who has assumed responsibility for contact tracing that setting. And we've actually reached 99.4% of all of the contacts identified by those settings. And I think that's a real something that we can take credit for in Greater Manchester. I think we have been ahead of the curve compared to most of the other areas nationally in relation to contact tracing for complex settings. And I think then there is learning we can take from that as we move forward with wider contact tracing. So Ryan, if we can move on to the next slide, please. So then, as I mentioned earlier, there are 2 other levels to the national contact tracing system that are delivered by national teams. So level 2, which deals with interviewing the index cases, and level 3, who are involved in contact those identified as contact and asking them to self-isolate. And there are a couple of insights I wanted to share with the committee today. The first one is that currently 24% of cases are not being reached by the national level 2 team, and that 46% of contacts who are identified are not being reached by the national team. And clearly that is an area of concern and something we are looking to address with national partners. One other area of concern relates to the average number of contacts that are provided by index cases. So what we're finding at the moment from the national data is that on average, when a person is interviewed who has been confirmed positive with COVID, they're disclosing on average less than 3 close contacts. Our assessment is that is probably an underestimate and reflects people not fully disclosing the number of contacts that they have been in contact with, which again is something we're looking to address at present. So key challenge that surfaces is that if a process such as is in place nationally at the moment doesn't reach sufficient numbers of cases and contacts, it does really limit the extent to which we can prevent and suppress the continued spread of the virus, because we don't really break the chain of transmission in the way that contact tracing, when done well, is very much capable of doing. So how do we actually address that? So what are the opportunities that sit in front of us? So firstly, you will have seen through your localities that we've got a significant programme of work ongoing at present with local and national colleagues to collaboratively design a locally enhanced and supported contact tracing approach for Greater Manchester. And the initial proposal that we've submitted to national government is that all cases and contacts that are not reached by the national team within 24 hours are escalated to the relevant locality within Greater Manchester for us to attempt engagement, building upon the wealth of local insight and knowledge we've got, the relationships we have with our citizens and our population, and our ability to mobilise credible resources such as the voluntary sector, community colleagues and the faith sector. By mobilising that, what we hope to do is reach far more people who are cases, reach far more people who are contacts, be more successful in encouraging those contacts to self-isolate, and in doing so suppress the spread of the virus and reduce the rate of infection. Thank you, Chair.
Thank you. Members, questions. If you wish to ask a question, use your chat board to say that you wish to speak, and then I can take you in order. Mark.
Right, thank you. So I'm first in, wow. Okay, a question regarding this. I'll use Bolton because obviously that's where I'm from as an example. I have great concerns at the moment because obviously we're top of the list in the country for transmission of COVID at the moment, and we have a testing centre on the old bus station in Bolton at Moor Lane. Lots of concerns have been fed in through to Dr. Helen Loy and onward from her to wherever in the national team, and we've been told that we are a priority for testing. However, the reality of it is that this isn't working. I myself took a test last week. I know other councillors and people involved here who've had similar problems, and it took me over 20 attempts to get the Bolton test centre to actually appear. I was trying to be sent to Trafford, I was trying to be sent to Stretford, to Rochdale, to Haywood, all over Greater Manchester and onto the fringes of it. And one of our people yesterday was trying to be sent 67 miles away to Telford. Yet when I pass the testing station here, as I do, it isn't very busy. Obviously something is going awry, and my fear is, and this would happen, I presume, to other locations throughout GM, if people cannot access a test locally through the national system of trying to book online, they may well just decide not to bother at all. Therefore, we've got the transmission rate, as we've perhaps seen in Bolton, will be pushed even higher because people won't comply with it. I wonder if that's the first part of the thing I wanted to raise there, and perhaps somebody would like to comment on it. The second part was, as has just been very well put by Dave Bulger, there is a worry that people might be reporting as little as 3 contacts when it comes to tracing who they've been in contact with. Most people will contact that number in their family alone, let alone friends and colleagues, etc. Would it be perhaps another string to our bow to perhaps push more testing into workplaces, because you will immediately know then a large number of colleagues that will be involved. You know, if somebody says I've only got 3 contacts.
Mark, I'm sorry to interrupt you, but can we let people, you know, so far I've heard you ask 4 different questions there, and I've got a queue of 5 other people. Martin, do you want to start answering some of Councillor Cunningham's questions?
Thank you.
Yes, certainly. Thank you, Chair. I'll start off and I'll hand over to Dave. So, Councillor Cunningham, what you raise is a very real issue at the moment, which is there is absolutely no doubt that the National Pillar 2 testing service has a real capacity problem at the moment. And the capacity problem is in the laboratories, and it's in the processing of the laboratories. And in order to manage that problem, what is happening with the national system is the number of local tests through the local testing services are being limited at the moment. Now, as you say, Department of Health and Social Care colleagues promise us that we are being prioritised in Greater Manchester, but we are seeing real problems with that testing service. We are working on a daily basis with Department of Health and Social Care colleagues about how to prioritise the right level of testing resource for Greater Manchester. But there are many different people who have come back this week and said that, yes, they have been referred to testing sites many miles away. Dave, do you want to pick up the other points?
Will do. Thank you, Luke. Thank you for that, Councillor Cunningham. I think there are probably two key responses in relation to what you said. The first one relating to workplaces. So one of the things we have done over the past few months is where we, through the GM Hub, identify a workplace that has multiple cases being escalated to ourselves. We've worked with the local authority and with testing colleagues to put in place mass testing to test entire workforces. And we've done that at a number of boroughs in Greater Manchester and a number of large workplaces, because it does allow us to really get an understanding of the level of prevalence within those settings, to identify who actually has COVID-19, to enable us to have those people isolating, but also to identify the number of contacts, and in some scenarios to require places to close until such a point in time as everybody who's had it and everybody who's been a contact can be safely considered to be COVID free. So it is very much something that is part of the toolkit in our response. In relation to the issue of the number of contacts, I think it is a real challenge, and I think it harks to two key issues for me. I think the first one is one of the options for people who can apply into the national system having had a positive test is that they can submit their contact details on a web form. And what we find is the number of contacts provided on the web form is significantly less than that is provided when somebody has a telephone conversation with somebody. So what we've requested from national government is a routine auditing of web form submissions to ensure that where it is clear that the number of contacts identified doesn't match the activity that somebody's placed on their submission, that is potentially followed up by a telephone call handler. I think the second thing is around the limitations with certain parts of our population of a national call centre. And actually, I think sometimes in eliciting a candid response from people and a full submission of who they've been in contact with, you need to build rapport, you need to build a relationship, you need to listen to people. And actually, that's often done better by some of our local staff. I think that's why we have possibly more success with our local system, is to be able to spend the time and be able to listen to people and be able to understand where they're coming from, to build that rapport, which in turn elicits much more detailed disclosure of people's actual level of contact. And so that's something we hope to build into the locally supported contact tracing model, which is currently being rolled out across Greater Manchester, where there'll be a far bigger role for localities, particularly for those cases not reached by the national team.
Thank you. Councillor Morris, I hope that answers your questions. Thank you. Councillor Dutton Ray, I'm sorry, you wish to ask a question.
Thank you, Chair. One question and a comment, if I may. My first question really is post-infection testing. A lot of my constituents are always asking, why can't we have a test to see if we've had this disease? And I just wondered, is there any advantage having this test to prove if you've had it or not? Is there any advantage for the public at large?
Thank you. At the moment, there is no clinical evidence to say that if you've got antibodies having had coronavirus, that prevents a secondary infection. Sorry. So that's a very live question at the moment, but there isn't sufficient evidence for that. So the short answer is no.
Okay, thank you. And my comment in it, well, more than a concern, I suppose. I've frequently gone into restaurants with this half price sort of like offer, it's just finished. And my main concern is that there's no control of people going in, putting in the right evidence of where they're from, phone numbers or anything. I've seen people writing Mickey Mouse, Donald Duck on forms, putting them into a box, and it's a farce really. I just wondered if we could introduce any more control, shall we say, on the ID proof and evidencing of people using these facilities.
So if I respond to that one, Councillor Dutton, I think it is a very real issue, and we see it playing out when we attempt to contact trace some of these settings, that actually gaining a full picture of the contacts who've been in those settings on the dates that there's an infectious person there is really challenging. And we've seen exactly the examples you described there with clearly false names. There's a lot of work going on within localities at the moment around enforcement, around working with hospitality settings on ensuring they are COVID safe and they are following those rules. But I guess my other key plea would be to the public. Actually, this is a responsibility for every citizen in Greater Manchester, that when we're going into those settings as a local resident, it's my duty actually to give those details to ensure that if somebody does test positive, I can be contacted, I can be advised to self-isolate. So actually, I think this is about everybody playing their part. And so yes, it is about hospitality settings, ensuring they have the right procedures. It's about localities ensuring that they're making sure those procedures are in place and that enforcement action is taken when necessary. But it is for the public to actually play their part. COVID hasn't gone away. And we're seeing that at the moment, and actually ensuring we can identify contact and contact them and be able to ask them to self-isolate is massively important in terms of keeping levels lower.
Thank you, David. Thank you, Chair.
Councillor Actor.
Thank you, Chair. I've got a couple of questions. The first one's obviously it's about the local tracing model. As the presentation has shown that that model actually works, and the national model has issues, and you suggested that we made a plea to the government to contact us 24 hours after they've tried to contact someone, and I think that those initial 24 hours are crucial.
Yeah.
And we should be able to get the data straight away, because we've proven that the local model works, and it's critical that we get out there and trace the individuals that particular person has become positive, has been in contact with, to sort of to eradicate the spread, because obviously in Greater Manchester it's a massive issue for us, and we need to act on it quickly. And I think it's important that we put the pressure on the government to give us that data sooner than 24 hours rather than waiting those initial 24 hours. And my second point was around the announcement that the Health Secretary has made this morning, that tests should only be available for people who got symptoms. But in Greater Manchester, that's a massive issue for us, because the data has shown that in Greater Manchester, younger people are testing positive, and a lot of those young people will not have any symptoms whatsoever. And again, it's these mixed messages are going to sort of increase the infection rate in Greater Manchester, and somehow we've got to get into the government and say to them, look, let us deal with our situation rather than you sort of sending out different messages on our behalf or nationally. I know it's a difficult question for you to answer, but my sort of, if you don't want to make a comment on it, but my sort of issue is to the Greater Manchester politicians to go out there and be more vocal in terms of putting the pressure on the government. And obviously you officers can't do that.
Thank you, Councillor Akhtar. If I respond in relation to the local tracing arrangements and the national tracing arrangements, and then Martin might want to come in relation to your second point. So I think we recognise the challenges with the national system. We are engaging with them, as you've articulated, back around the locally supported contact tracing model, whereby we already, by the end of next week, will be picking up in all GM areas the case is not reached by the national team within 24 hours, and then following on with a further request that we have the same option to do that around contacts. In terms of the data, local areas do receive live data now in relation to test results and receive daily line lists of everybody who's tested positive. The challenge is actually that there isn't sufficient capacity to contact trace all of those people at a local level at this point in time. And so we do still need the resilience of the national system until such a time as we do have sufficient capacity to potentially look at doing something that was entirely across Greater Manchester. That is very much part of the discussions that are taking place at present. But for now, the focus is very much on those not reached by the national team within 24 hours.
Thank you. And Councillor Akhtar, I've not seen Secretary of State's announcement this morning, so obviously can't comment on that. But I think what we're talking about here is, with limited test capacity at the moment, it's directing that limited capacity to the right places, be it geographic in terms of Bolton with the particular issues that they face at the moment, or be it about particular members in the community.
Okay, I'm moving on. Councillor Smith.
Thank you, Chair. Yes, I've got a couple of little questions, really. I hope I'll make them short. The first is just something that occurred to me during the last replies, really, about contact tracing and people not disclosing sufficient numbers. If you get a phone call from somebody claiming to be from a national body and ask you who you've seen in the last 24 hours and explain that you've been in contact with a person who's tested positive for COVID, is it not possible that a lot of people aren't believing it? Because you get scam phone calls all the time. I'm always getting phone calls from people pretending to be from the HMRC and telling me I owe them money. So is it not possible that the local idea and that what you said about building up a relationship of trust is a vital step in this procedure? And I don't know if that's occurred to people, that they're ringing people up and they're not believed. That's one possibility that I'd like to suggest. But secondly, I'd like to ask about when you mentioned about the consequences of the complex tracing procedures, and in particular schools. In my ward, 2 schools now have sent home the reception and nursery classes because of cases that have occurred already, although they've only been back 3 days, and another primary school that I know of. Now, it's the childcare problem here, isn't it? If you've got children sent home, parents are going to have problems if they're at work, and do the parents have to isolate? So I don't know how much detail has been put into trying to sort that out. There may be a whole class of children that have been sent home and need looking after, basically. Is it possible to do that together, or is that not allowed? Is it not part of the isolation? And the third question is about what you were just talking about, David and Martin, about the capacity for testing. The new saliva test, which you've mentioned in the document, but you haven't mentioned verbally, that's being trialled in Salford. I don't know how that's going, but would that help? Obviously, that would help if it can be rolled out. How close are we to getting it rolled out, and have we got an update on how it's going? Thanks, Chair.
Martin.
Dave, do you want to take the first 2 points and I'll come back in on the third one? Yep,
so if I take the first 2 points, and in the meeting chat, Katrina Stevens, who's the Director of Public Health from Oldham, has also suggested she may be able to come in. I think there is a particular point that she could make as an area that is already delivering locally supported contact tracing. So Councillor Smith, certainly in relation to the calling from a national number, that has been something that's been flagged up by a number of people, and in the areas that have tested locally supported contact tracing, actually being contacted by somebody locally from a local number who can validate who they are has shown some advantages. The national system does have the ability for somebody to challenge who they are and to have that. There is a process whereby reassurance can be given that the person is who they are, but I do think it can be a barrier for some individuals in our populations who will be naturally anxious about an unsolicited call to them from a national number. So actually this is where some of the locally supported contact tracing may add an additional enhancement to what is going on nationally. I think in relation to schools, I think it remains a really challenging situation. What's very clear is where we do have a case within a bubble within a school, then for the most part that bubble is asked to self-isolate, and for some schools that is one class, for some school that is more than one class. And when we talk about self-isolation, that is the individual in their own home, not self-isolating with the wider group. It will cause some disruption for parents. I'm a parent of a 6-year-old myself. I am waiting for that call, ironically enough, as to whether that will affect me. It's something that's unavoidable. It's the balance we're trying to strike at the moment between children returning to school, keeping them safe and suppressing the virus. So it is very, very challenging, but it is important people do follow the advice that is given, and when they are asked to self-isolate, that they do so. It is really one of the key one of our key things in terms of suppressing the virus and stopping it spreading further. I do wonder, Chair, if it is worth bringing in Katrina Stevens to talk maybe a little bit about the value they've seen locally of locally supported contact tracing, because Katrina is living it on the ground.
Good morning, everyone. Yeah, we've had the locally supported contact tracing in place in Oldham for just a few days short of a month now, and the same's been the case in Rochdale. And we've certainly seen that the number of people who are successfully contacted has gone up in that time. So there are definite benefits to having that local system. As Dave says, having a local number has been an important factor. One of the other things that we've had feedback on is that people find that having a number that they can call back for a bit more information as well is really helpful. And I think another key finding that we've had as well is that within the national system, what can't be done at the moment, it seems, is to link families together. So where you've got multiple cases in the same household, often people are getting many phone calls over a number of days. And actually, with having a local system, we can do some of that matching and actually reduce the number of calls that families are getting, and just speed up that process a bit, if you like, and stop people being bombarded with phone calls.
Good, thank you.
Thanks, Stella. Councillor Morris.
Sorry, Chair.
Just to respond to Councillor Smith about Salford and the saliva test, John, it is starting off very slowly. Initially, it was just targeted at 250 people, and then it will grow as more capacity becomes available. We are very lucky in Salford to have this, but as I say, the progress at the moment is slow and steady. So I haven't any more to say about that, but we are progressing it.
If I may, Chair, to just pick up on the issue of saliva tests. So in Greater Manchester, we are only the second area in the country who are piloting saliva tests, the first being Southampton. And we have 2 pilots at the moment in Greater Manchester. The first pilot, as we've already mentioned, is the testing in Salford of members of the community. And the second pilot is testing NHS staff in Manchester Foundation Trust. There are a number of parts of this pilot. So the PCR antigen testing that we've been talking about today is what's known as nasal pharyngeal testing, which is a very posh way of saying somebody sticks an enormous cotton bud up the back of your nose and up the back of your throat, and anybody who's had this knows that it's very unpleasant. So saliva testing obviously is much less pleasant. The potential is that the capacity to do tests will be greatly increased through saliva testing, but this is very much piloting at the moment, and part of this piloting is we are comparing what's known as the specificity and the sensitivity of saliva testing against traditional testing to make sure that it's as good a test. So it's exciting, but it's very early days.
Can this committee be kept updated with it then at our next meeting or whenever, please?
Absolutely.
Yeah. Okay, thanks, Stella. Right, have we any more members waiting to ask a question, please? If not, I have 3 questions for Martin before he goes. Okay, Martin, I think the first thing is that I would ask that all committee members go back to their councils and emphasise the need for local testing, for local systems, because there we have people who know the geography, know the people, and are more likely to elicit the information. So I'd ask all members, all councils to support that. Two problems that worry me, Martin. It might sound rather draconian, but there was a report I saw over the weekend about the number of thousands, not hundreds, but thousands of people returning from holiday who are not self-isolating from areas that they should be. Now, in GM alone, I saw there was a fact that something like 800, I can't remember if it was 834, 864 people were notified. But when the police went to them, only 2 of them were issued with fixed penalties. I've already tabled this as a question for the leaders' meeting this week, because quite honestly, that's frightening that only 2 fixed penalties there. We have to make a little bit more ruthless. If you are going through on holiday, if you're going to come back from an infected area, you have a moral duty not to infect others around you. And if you can't do it on your own morality, then I think we have to start imposing penalties. And I don't know if this was at all possible. We talk about issuing fixed penalties, but when people go to restaurants, pubs, etc., and fill in contact cards, if they're found to be putting down stupid data like Donald Duck, firstly, the duty of the pub, hotel, whatever, should be to ask for proof of evidence. And if they refuse to do it, then they can't be served. Any false evidence should be treated as an offence. And again, I would look to you guys to push the idea that we do start making it an offence and issuing fixed penalty tickets. We cannot afford to sit back and allow this to get out of hand again, as we did back in March and April. tracing these holiday returnees, Martin, do you think we've got a grip with tracing these people when they come back off holidays, they return to Manchester Airport or Liverpool Airport?
I think both yourself and Dave have made a really excellent point throughout this conversation, which is even with almost unlimited resources, we would rely upon the public to play their part here. We cannot police every aspect of people's lives here. And I know that in councils, your enforcement officers are working with local businesses, with local restaurants about how to do this, how to work in a very different way, how to live our lives in a very different way. But I think what we need to do is we need to constantly remind the public of what is, I think Dave said, and he said it very well, their moral duty not only to protect themselves, but their workmates, their friends, their relatives, particularly their elderly relatives. And I don't think it will be possible to police that. And I don't mean police it in a uniform police sense, just mean police in the sense of operating a system.
You mean monitoring it?
Yes, absolutely, monitoring. So we have to constantly get back to the message to the public about why it's important, why by doing this we'll be able to get back to more and more of normal life, and we need to act in the common good.
Yeah, again, Martin, I come back to the fact we have to be a little bit more emphatic out there, especially when we look at who are the current major problem, and get out to them. I think the message about don't kill your granny is one step towards that, but we've got to make people be aware that they do have that responsibility. They are potentially, if you think back to March when those medics came back from skiing in Austria, not realizing they'd had infected Italian guests at the same resort. That was the first real hub that started in the UK that we recorded, if I got my data correct. I think that was very early March. I do see that since then that the manager of that ski resort has been prosecuted by the Austrian authorities. It was a little bit late. It just proves that I think it was 5 people came back from Surrey, and it escalated very quickly from then. I'm looking back at the figures. As far as the saliva testing, I saw the report last night that say that it seems to be effective at the moment, but I think it was Stella who made the point. We do need to have that comparison between the unpleasant test and the possibly lesser unpleasant. I think both were quite invasive. Thank you very much for your presentation, and members, thank you for the questions. I think, Martin, you've got to go almost to the minute now. You're 30 seconds over time. Thank you very much for input this morning.
Thank you for inviting me.
Okay, members, we've caught up some time, so could I suggest you have a 5-minute break if need be for whatever reason, and we come back on at 11:05, if that's okay, Jenny? No feedback.
That's fine, Chair.
Right, members, are we ready to start again?
Aye.
Thank you.
Yes.
Okay, so Warren, are you ready?
Maybe just giving us 1 more minute, Councillor O'Brien.
Yeah, we are got a few seconds yet.
Yeah.
Joanne, can you ensure that the members get those slides sent out to them, please?
Yes, we'll do, no worries.
Thank you.
John, while we're still waiting, could I ask you a question?
Yeah.
I just wonder, is there a laid down procedure? I mean, while I've been on this break, I've received 2 phone calls from constituents complaining about members of the public it's not applying the safety rules with COVID. I just wonder what the actual correct procedure should be now for reporting this.
I think Dave would be better to answer that, Ray.
Yeah, seems so strange. I've had 2 calls in the 5-minute break, all reporting misdemeanors, shall we say.
I can answer that one if that would be helpful.
Please.
Yeah, so well, I can answer from an Oldham perspective, but I wouldn't have thought it'd be drastically different to in other boroughs. So calling the local police number or reporting them via the GMP have an online reporting form that you can use to report incidents like that. And as well, depending on the setting and where it is, local environmental health teams are often collecting those reports as well.
Thank you,
Very
Katrina.
helpful. Thank you so much.
Warren, do we have you yet?
We do, yes.
Thank you. Would you care to introduce this report, please?
You just turn your camera on, please, Warren, so I can send you live.
It's, oh, no, it might be because my camera's on. Has the picture gone?
Yeah.
Oh.
Well, no worries.
Can you still get would my voice still go?
Yeah, we can still hear you. I'll
shall
just
I-
put Councillor O'Brien live. Okay, as the chair.
Okay.
Right, Warren is to introduce the report and we'll call on colleagues in support of the item, including Tracy Vell from Primary Care, Bernadette Enright from Adult Social Care, Sandy Baring from Mental Health, Fiona Noden from Chief Executive Bolton, and Silas Nichols, who's Goal Commander. So please note, and you can question at the end of the presentation. Warren, away you go.
Thank you, Chair. So what we've drawn together, both in the report and then we'll try and assist with the headlines from the report in the presentation that follows, is a description of the way that we've organised ourselves from the initiation of the national management of the of COVID as a pandemic, how we've organised ourselves in Greater Manchester, and then a walk through some of the headlines of the key areas of work, as you said, affecting primary care, adult social care, the work of the hospital sector, the organisation of urgent emergency care, mental health provision, and towards the end, just some pointers in terms of our approach to recovery and the restoration of mainstream services, and then we'll be able to invite questions and comments from the committee then. So we could just move on to the first slide, Ryan, and I'll just set out a bit of the context and the organisation. So I've covered there what we'll go through in the next set of slides. If you just move on to the next one, please, Ryan. So this was declared a national level 4 incident on the 30th of January, and in Greater Manchester, that meant that we were coordinating ourselves from the NHS perspective as part of that national incident management that was run through the entire country, with broadly a consistent approach to the organisation and coordination of services in hospitals and services across the rest of the NHS. And within Greater Manchester, we were also participating in the coordination through the strategic coordination group, organising ourselves and coordinating ourselves with other public services to ensure that the full range of consideration and support to residents was brought together in a coherent way. It meant, as part of the organisation of health and care in particular, that we established a hospital cell and what was described as a community coordination cell, where we were able to bring together representation from primary care, adult social care, mental health provision, voluntary and community sector, and used that arrangement to coordinate the health and care response to the COVID pandemic, both in line with Greater Manchester's overall response, but also with a clear connection to the regional incident management as part of the NHS arrangements nationally. If we move on to the next slide, please, Ryan. So I'll just say a bit about the two cell functions. So the hospital cell, chaired by Sir Mike Deegan, Chief Exec of the Manchester Foundation Trusts, and a vehicle for the collaboration and coordination of the whole of the hospital sector in Greater Manchester. So I think starting with an advantage of the extent to which Greater Manchester's hospitals have worked together over a number of years. So this wasn't a set of relationships which needed to be initiated because of COVID, but it was a set of relationships which have a long history of working together. And the key tasks and functions are set out in the slides and focused in particular on securing the right level of critical care, bed capacity and clinical capacity, but also thinking of the full range of challenges and restraints that would exist across the hospital sector. So also needing to support those processes of both equipment provision and the coordination of mutual aid across the sector as well. And although that was initiated in March, that arrangement continues and is forecast to continue throughout the process of the ongoing management of the COVID pandemic, but also coordinating the support of the restoration of mainstream services and managing the process of tackling any backlog in waiting lists and for planned and other care as well, which we'll say a bit more about towards the end. So we move on to the next slide and the community coordination cell. So that was chaired and is chaired by Sarah Price, the interim chief officer of the Health and Social Care Partnership, with a similar remit, albeit across a different range of services to the hospital cell. So needing a daily line of sight to capacity in community settings, needing to support the system to coordinate its activities and both support the here and now response of non-hospital services for people requiring care on the day, but also coordinating the system to support discharges from hospital, which remains a requirement. But obviously at the outset of the pandemic, at the point we were looking to secure and create the capacity for critical care, that was a significant and major area of focus of the work. And in line with the hospital cell, that process around collaboration, cooperation, and the coordination of mutual aid across all parts of the system was the facility that we were looking to and have then coordinated through the operation of those two cells. Next slide, please, Ryan. So a bit of a description here of how the sort of pieces come together with the individual key work streams of the two cells and also then the line to the Strategic Command Group chaired by Eamon Boyle and Chief Constable of GMP. And you can see there is both the reflection of core health and care provision there, but also the participation of the health and care system into the strategic command group and their particular work streams around things like PPE provision, which was a critical kind of enabling factor for us early on, humanitarian assistance and the coordination of the whole system around shielded and vulnerable patients through the community hubs and so on. So that was the coming together of each of the areas of work that has figured through the whole of the pandemic response, and this infrastructure is largely still in existence and supporting the ongoing recovery work as well. So if we move on to the next slide, and this is the point where we'll just get into. Sorry, I'm going to have to. That's it. Well done. If we leapfrog to primary care, and this is the point where I'll just introduce a few colleagues. We'll kick off with Tracy. He'll just be able to get into a bit of the detail of the work that's taken place and what the key considerations looking forward are. So I'll hand over to Tracy for primary care to kick that off.
Thank you, Warren. May I just check that you can actually hear me as I've dialed in on my phone?
You're fine, thank you, Tracy.
Great, thank you, Chair. So just introducing myself, I think I've met most of you before. I support the Primary Care Provider Board and our wider primary care providers, Greater Manchester. So I'm just going to whiz through some of the things that we've been doing in order to support citizens' care during the COVID crisis. So, as you know, general practice has remained open, but has needed to adapt swiftly for the protection of the public. Some of the routine services were temporarily stopped due to NHS England suggestions, and we've tried to enable urgent access, bearing in mind that face-to-face consultations have been subject to the correct infection protection and control in small areas such as small practices. So we've enabled 100% of our practices in Greater Manchester to adapt to a digital access whilst remaining open for face-to-face or telephone consultations. We've also enabled video consultations and the chance to access your practice to make all sorts of requests, and we can triage those requests and still offer as full a service as we can. Capacity is reduced to see patients face to face, as you will all know and understand, due to the infection control and the needing to make sure that not many citizens are in waiting rooms together and that sanitisation takes place, as we were seeing some cases that we were unsure of the status of COVID in the early parts of the pandemic. Early on in the pandemic, protection equipment, personal protection equipment was a difficult problem. All of primary care, that includes our wider primary care colleagues as well. Just to talk about wider primary care, it was adapted in that routine dentistry would only consult remotely, and we stood up urgent dental centres in initially 2 of our localities and then throughout our 10 localities. The routine dentistry was not terribly well advertised, but deal with some advice and antibiotic prescribing. Routine optometry closed, and we were enabled in GM to roll out some of the emergency eye services that we'd done previously before COVID, and we now have one in each locality that deals with emergency eye care, such as red eyes, worries about sight loss, lots of the urgent conditions that need urgent care within an hour. Just talking through the slide swiftly, we've enabled sight of our workforce in primary care by having reporting daily from all of our 467 practices. They report on how much capacity they have in terms of workforce and how much PPE they have available, which has allowed essentially a GM delivery of personal protection equipment to keep those practices enabled to see face-to-face patients. We've also put a lot of work into the care sector. So before COVID, we worked very closely and in some of our localities remotely doing ward rounds in care homes to ensure that care home staff feel supported by our health service. General practice has allocated a single representative for every care home in Greater Manchester, and we've enabled that digitally through a assessment app to be used by carers that feeds into a dashboard that can be seen in general practice to look at early signs of deterioration. In our practices, we've also enabled risk assessment for vulnerable workforce, particularly BAME staff, shielded and vulnerable staff, and 95% of our staff have been asked to complete a risk assessment, and that's been undertaken so we can protect and keep our workforce in the workplace. Due to escalation worries around the number of cases of COVID, we did two things. We set up a locum bank in Greater Manchester to allow access to other workforce members in terms of general practice nursing staff and GPs, so that we enabled practices that were becoming vulnerable when reporting in on the daily reports. We allowed them to access quickly extra staff. We also enabled a GM-wide death certification service, which, due to the fact of the numbers of deaths that were anticipated, we needed to rapidly roll out the changes in death certification legislation. And this was continued for a period of time at the peak and has now stood down, and death certification returns back to practices with the education involved in the different way of reporting this. I think that's probably all that we have on the slide. I'm aware that there'll be lots of things to discuss in question time later, so I've just kept it brief for now, and hopefully that will be helpful. Handing back to you, Warren.
Thank you, Tracy. Warren, are you coming back? Bernie, where you go?
Do you want me to carry on there?
Please.
Okay, so if you could just move on to the next slide, that would be great, thank you. So yeah, right, I'm Director of Adult Social Services for City Manchester. I'm here today representing 10 DASs across Greater Manchester in terms of our response across adult social care for the pandemic. And so the first thing I would like to say is we recognised early on, in response to the national requirements and the Greater Manchester Directors of Social Services work on living well at home, that we needed a more joined up collaborative approach across the 10 localities across GM to enable us to respond to the pandemic and share best practice, provide mutual support and escalate risks and areas of concern where we needed to. And it's fair to say in Greater Manchester, thankfully, we were fortunate to have strong integrated health and social care arrangements in place, which supported us in managing our response and continues to support us in managing our response. So this articulates the Living Well at Home programme, and on the next few slides I will go through a little bit more detail of the particular areas highlighted. Moving on to the next slide. A lot of work has taken place to strengthen our support, particularly to care homes for care providers, and Tracy's obviously articulated some primary care support, which has been valuable throughout the period. Particularly in relation to infection prevention control, we have been working closely with all partners to try and ensure that we control the infection within care home settings, supported tenancies, etc. And particularly in relation to workforce and the clinical pathways of support from primary care. So if I move on to the next slide, primary care support trade has already gone through in terms of trying to ensure care home staff have the appropriate levels of support and care home residents have the appropriate levels of care. So they have articulated that support. So I'll move on to the COVID-19 testing. I suppose I just want to make the point that within Greater Manchester we have, as Warren has said, and it's articulated in the community cell slide, we've taken a whole system approach across health and social care to reduce our infection rates. We absolutely acknowledge the huge challenge faced in particular by care homes, and we've provided support, and this has been supported by the allocation of the Infection Control Fund. I think it's important to note that we did put a 9-point plan together in relation to a risk assessment for infection protection and control against the grant conditions that were laid down by the government to ensure we're doing everything we could that was possible to support the care homes, to support vulnerable people to stay safe and well. And in addition to this, we had real-time reports that we developed directly with providers, where we had real-time information letting us know their levels of infection, levels of staff absence, levels of PPE supply. So we're able to support them and respond quickly, provide training where necessary, and mutual aid across GM. So I'm not sure what slide we're on, but I'm just going to say a little bit about the COVID-19 testing. So the DAS's directors of social services and the directors of public health have been working closely together throughout the pandemic with our colleagues in the NHS to ensure testing in care homes across social care is more joined up and the capacity is targeted into the right places. The slide does articulate some of the areas that we've managed to put significant improvement in, and obviously we've just started our whole care home testing, 7 days, every 7 days to staff and 28 days for residents, which is really, really crucial. I think it's important to say we're also progressing how we can test all the people visiting the care homes now, and we're working with the national team around that. And we've also worked with the national team around the pilot for asymptomatic testing, and we're just about to roll that out within supported living and extra care as well. We've also worked with them on a pilot around antibody testing. Where there is an outbreak, the care home gets direct support from the infection control and public health team straight to the care homes, and really importantly we support them in the discussions around business continuity, plans if staffing levels do go down, and what we can do to make sure we safely support people to carry on living in their home, which is a care home. Sorry, can I move on to clinical support now? So I don't know what slide we're on, apologies. So clinical support, obviously Tracy's already articulated some of that, but the training on infection prevention controls has been really important, and PPE and swabbing as well as nutrition and hydration. A whole range of areas where we've provided enhanced clinical support to care homes. And I suppose moving on to end of life care, sadly, we all know a number of COVID-related deaths have occurred in care homes. So the hospices have provided tailored support to care home staff who are obviously managing the deaths of significant numbers of people in their care, and also supporting families. The Greater Manchester discharge pathway, Warren has referred to this. At the start of COVID, obviously we have the rapid discharge programme in March, where we were trying to support our acute colleagues to create as much capacity as possible to ensure people who needed to be in hospital were able to be admitted. So we were discharging people as soon as they were medically fit through our discharge to assess referrals. Really importantly, we're testing care home residents before they go into the care home and ensuring that safe care can be provided to them on discharge. Obviously, 2 weeks supply of medication is really crucial as well, so that they can have continuity of care. And the community multidisciplinary rapid response. This, again, through our integrated arrangements across GM, we have this in place and we were able to utilise it to be able to respond in a really timely way to support people where clinically appropriate to avoid hospital admission and have support where they were. If I can move on to the next slide, that would be great. I'm hoping the next thing on your slide is workforce, because I can't see. I hope so. This is a really important slide, actually, part of the slide, the workforce. The pandemic, as we all know, has absolutely highlighted the valuable and essential role of social care play alongside our health colleagues in the system. And we want to celebrate that. And we've obviously got the Care Heroes recruitment campaign. We've got the Bring Back Staff campaign. We've got our virtual training and mental health and wellbeing offers to staff across both health and social care, acknowledging this is a very difficult time for everybody working in the sector, and we want to make sure we're supporting them appropriately too. With regards to PPE, Tracy has already referenced to primary care. This was a real challenge at the start, as it was for social care. But we came together across GM. We developed a GM PPE personal protective equipment task force. We've got hubs in all 10 localities. We've got ongoing procurement of appropriate levels of stock, and we have live data from providers to enable us to ensure how much stock they have and if they're running low. I have already mentioned our support for staff, and that's where the emotional resilience comes in. And again, the hospital provided really valuable support and training to our staff in the sector. And data, digital and technology, we've seen really improvements here. And one just to note is the provision of iPads and tablets within care home settings so that loved ones can keep in touch with their loved ones, which is really critical whilst we've all been in lockdown. And obviously we're really mindful of the effect that has on people living in residential care 24-hour settings, not being able to see their loved ones. So I think I just wanted to stop there. Happy to answer any questions.
Thanks, Bernie. And I think for the next section, we're into Silas and Fiona representing the work across the hospital cell.
Thank you, Warren. If I cover the next slide, please. So I'm Silas Nichols. My day job is the Chief Executive at Wrighton Woodland Lee Foundation Trust. But over the past several months, I've also been acting as the Goal Commander for Greater Manchester. Goal Command sits under the strategic cell that's chaired by Sir Mike Deegan, and the function of Goal Command is basically the day-to-day coordination at a tactical level across the different providers that are present across Greater Manchester. We've been working in effect in 3 phases. So the first phase was the immediate response to the pandemic when we were right at the height of it. The second phase was then really about restoration and basically stabilisation of healthcare services. And then the third phase that we're just going into at the moment is then about recovery, about getting our planned elective services back on track. All of this, however, in the context that we still don't know quite what's going to happen with potential second wave. So we've always got that kind of eye on the rear view mirror, if you like. You could have the next slide, please. So this just lists the organisations that are involved and covered by Goal Command. I think the key thing to draw out here is that this covers all providers. So we talk about a hospital cell. There are a number of organisations there that provide mental health services and also community health services. And we have also throughout this been maintaining very strong links with colleagues in primary care, as well as also with colleagues within local government as well. So it's been very much a joined up approach. If I could have the next slide, please. In terms of our sort of phase 1 focus, the first thing to say is that Goal Command operated on a 7 days a week basis and also operated through extended hours. So quite often we would be meeting late on Saturday evenings, early on Sunday mornings, and sort of throughout the week as well. And I think that was important because the COVID doesn't work 9 to 5, and we needed to sort of make sure that we adapted ways of working that reflected that. Our focus was very much around making sure that no one organisation sort of went under with the pressures, and I think all of the committee members are probably aware of the quite heartbreaking scenes that we saw coming out of parts of Italy and parts of Wuhan and elsewhere, with hospital corridors overwhelmed with patients, critical care clinicians having to make awful decisions about who to sort of put onto the last ventilator, and indeed some pretty disturbing images of people having to make homemade PPE. we were very clear from a GM perspective that, you know, we felt it imperative that we avoided any of those type of scenarios or situations arising and putting our patients, putting our staff at risk, basically. What that meant was that we basically established some very robust systems of daily monitoring and forward planning around PPE, also around critical care provision. We had fantastic support from the military. We had a couple of military liaison teams assigned to us as well, who very much helped us with the logistical planning and also the physical movement of goods and equipment. And similarly, we also worked really closely with Greater Manchester Transport Authorities as well, again assisting with that movement and transportation of supplies. From a PPE perspective, we physically moved stocks of PPE both around the city region and also where PPE became available and elsewhere in the country, literally sending trucks down the motorway to pick up supplies and bring them back up to Greater Manchester. And also at times when we were able to support colleagues in nursing home sectors or elsewhere, sharing resources back out the other way as well. We also really focused around critical care facilities, again ensuring that no one critical care unit became overwhelmed or overloaded. And what this saw us do was at times physically, safely trying to how to clinically transfer patients from some of our outlying critical care units into some of the central units that we had within Manchester and within Salford. And we also did the similar with equipment, making sure that equipment supplies were flowing around. I think one of the factors that was we hadn't anticipated was oxygen supply to hospitals was critical because when you're running multiple intensive care units, multiple ventilators, multiple CPAP machines, that has a huge demand on oxygen supply. And I think many of us became kind of experts in the engineering of oxygen systems pretty rapidly over the course of those several months. And then the final thing which we sort of very much focused on was also the use of the independent sector. The independent sector was pretty much dracooned, if I can use that term, over to the NHS. And what we wanted to ensure was that we did that in a coordinated and controlled way to make the best use. And that basically was a mixture of at times taking equipment from the independent sector to use in the NHS, at times moving NHS patients into independent sector hospitals, and at times actually moving staff from independent sector providers into NHS providers to provide further aid and assistance. Could I have the next slide, please? So I think the next phase was, as I've mentioned, is about that sort of stabilisation. And if I could have the next slide, please, I'll hand over to my colleague Fiona Noden, who is the Deputy Commander for Gold Command. Fiona, over to you.
Thanks very much, Silas. So I have the pleasure of being Silas's Deputy for Gold Command, but my day job is the Chief Executive for Bolton NHS Foundation Trust. So as part of our response and our continued improvements regarding phase 2, we very much led a bottom-up approach around capacity and demand planning, so using the services locally, using our clinicians to make sure that we could provide services safely for our patients. Making sure that we had enough PPE, as Silas mentioned before. I think part of our planning assumptions have been very much led through our clinical teams, specifically through the functional director group, so the chief operating officers from every organisation, the medical directors from each organisation, the chief nurses, all working really closely together. So it became a system by default principle regarding how we manage health services. So we looked at two specific areas. One was endoscopy, so we created a single service management for endoscopy, realising that endoscopy was a key to turning services back on, both from an acute point of view, but also to ensure that we could retain our cancer performance across Greater Manchester. Endoscopy is a key diagnostic for our cancer patients. So we've been looking at how we can provide services across Greater Manchester, innovatively looking at how we provide services quite differently and looking into how we can support organisations to potentially ensure patients are given choice around where they can be have their diagnosis. And the final point I'm going to cover is that CCO beds. So we were working with the community cell regarding the CCO potential that we were offered by the NHS. So this was to look at how we can provide Nightingale centres in each locality, so we can ensure that patients are dealt with in their own area rather than having to go to a Nightingale centre. We work very closely with the community cell to ensure that the provision that we would provide was the right provision across GM for each locality. Unfortunately, the CECOL beds didn't come to fruition due to funding, but that it's still there. The fact that we work together, the fact it's an example of how closely that the two cells came to ensuring that we could provide services was a really good example of how we can work together for the future. So at that point, I'll hand back over to Silas. So thank you.
Okay, thank you, Fiona. If I could have the next slides, please. I'll just take you through 2 further slides and then I'll pause there because I'm sure colleagues may well have some questions for us. So one of the issues that we're now focusing on in terms of the recovery phase and preparing for the winter months is how do we sort of manage urgent and emergency care, which is what UEC stands for. I think all of us know winter, it tends to be a difficult and challenging time for the NHS and also for social services. And I think this winter will be no exception to that. I think that the other 2 complicating factors that we have, one is that we know we will see, as per normal winter, an increase in the numbers of people coming through our doors with flu or flu-like symptoms. The difficulty there is that until you've actually had the test for COVID, it's very difficult to determine whether somebody's coming in presenting with flu or whether somebody's coming in presenting with COVID. Until we have test results, we have to treat any suspected patient as a COVID positive patient and all that entails. Similarly, for understandable reasons, we've been asked to put in enhanced infection prevention and control measures, still maintaining very strict social distancing within our clinical areas. The net effect of all this is that it doesn't make it very difficult to run services in the way that we're used to. Not least, one of the things that we wish to avoid is having very busy and crowded emergency waiting rooms in our accident and emergency departments. One of our responses to this is to be introducing a new system of booked appointments for emergency care. So whilst some patients are absolutely obvious patients who need emergency care, so have been involved, say, in a road traffic accident, we still do have large numbers of patients coming through our doors who do need urgent care, but it isn't life-threatening care. And what we're proposing to do for those patients is introduce a new system whereby they would ring through to the NHS 111 system, and we're going to be advertising that and encouraging that through various communication channels, and then they will be clinically assessed via that service, and that will be a clinical assessment by either doctors or by nurses, and then where appropriate, routed to same-day responses that aren't emergency care. That could be an appointment within primary care, not necessarily at their own local GP, I have to add. It could be coming into the hospital, but not necessarily going to an A&E. It could be going straight to maybe diagnostics or going to see a different type of doctor. Or it may be actually, yes, you can come along to A&E, but come along at a set time and actually have an appointment to come in to see us. The next slide, please. It's got quite a busy slide, but basically what it boils down to is that it's, as I said, that will be through a core handling system. The core handling system will be clinically led, and then they'll be looking to route and move patients to the most appropriate venue for their treatment. We're looking to introduce this system in November. It will be done through a phased rolling approach, and we're not alone in doing this in Greater Manchester. Similar approaches are currently being trialled out in Blackpool, Warrington, and down on the southeast coast as well. So, and some of those trials have been sort of going for some time now, basically. I think that's the end of my slides. I will pause there, Chairman, in case there's any questions for myself or Fiona, if that's okay.
Thank you, Silas and colleagues. Right, Ray, yeah, counted that you were the first for questions.
Thank you, Chair. More of a comment, really, and I'm not sure if correlation's the right word to use here, but there appears to be more positive COVID testing now. It's on the increase, and yet we seem to have less people in hospital beds. Do you believe statistics are sending the wrong message? And I'm guilty of this, that I'm always looking for how many deaths are in the country, and as it's very, very low, it's sending the wrong message to me that we're through this epidemic and things are improving.
I think it's a very good point, Councillor. I think there's various theories and hypotheses around what's happening. It could be that just more young people are catching COVID, although the data doesn't really seem to bear that out. It could be that perhaps the virus is mutating and we're seeing different strains. What I would caution against, though, is that there's always a lag time between the numbers increasing and then the numbers of people who then progressively become more ill to the point that they actually then require hospitalisation. And then typically once somebody is hospitalised through COVID, it can be another 2 to 3 weeks before if they unfortunately going to have a terminal end to their treatment, you actually see that death occurring. So what we may be seeing is the beginning of a tail, which, you know, a month down the line might start seeing an increase in mortality. So I do think there is a danger of mixed signals coming out on the back of this.
And if I can add that as well, Silas, thank you. I think if we look at France, we know that there was a peak that started to become a second peak in their number of patients being patients being tested and their positive environments, and then there was a 2 to 3 week lag of patients being hospitalised. So it's really up to us to make sure that we're preparing for our second peak.
Councillor Smith.
Thanks, Chair. Yes. First of all, can I just thank all the officers who've given these reports this morning, because they've been extremely comprehensive and thorough on a very wide range of areas and services. So thank you all for that. And I think as a very brief comment, what it has shown up is the absolute vital necessity of coordinating and integrating health and social care, which we were doing, but perhaps rather too slowly, and maybe the COVID crisis has accelerated that. I've got 3 short questions. One's on the what you've just been talking about, Silas, about access to A&E and how we've been trying for years really to reduce the pressures on A&E, and we haven't managed to do it. And the new system where people have to ring 111 first sounds like a very good idea, as long as they can get through to 111. So I would ask very carefully that the capacity of 111 to cope with the calls quickly, so that people don't just think, oh, I'm fed up with this, I'll just go down to A&E. We don't want that happening, and so that must be a priority, mustn't it? And also in hospitals, it's now become very, is that they're obviously very COVID conscious, and people who are coming in either to A&E or to outpatients aren't allowed to bring anybody with them, and that's fair enough because it's hopefully reducing the risk. But for some patients, this is going to be very upsetting. Either they need some support physically or emotionally, or they're frightened anyway. And although I understand why it's happening, I just wondered how long it was likely to go on happening. And my other question is about the homeless. There was quite a substantial piece on the homelessness in your written report, and about how they've been allocated to hotels and allocated to GPs if they weren't already allocated to GPs. So I wanted to ask if that was a complete process now, and if basically how much longer it was could continue. And obviously the bed every night scheme has been successful, but it's not destroyed rough sleeping altogether. And I just wondered how you could help me on that. Thanks.
Okay, thank you. So in terms of the capacity of NHS 111, you're absolutely right. The issue here is making sure that people can actually get through to 111 in a timely fashion. The lead employer for 111 locally is the North West Ambulance Service, and they've been running through a recruitment campaign over the summer months to increase the numbers of call handlers by several hundred. I don't have the exact figure in front of me right now, but we can get you that figure should you wish to see a counsellor. In terms of the visiting, we progressively have reviewed the visiting arrangements on an ongoing basis. We have relaxed them in 1 or 2 areas, so in particular in some areas around maternity, also in some areas where patients either have learning disabilities, communication issues, and indeed where patients unfortunately on the end of an end of life sort of situation. As ever with this, though, there's always a fine balancing act between respecting the needs of patients and recognising that emotional support, but also recognising that hospitals can be a source of onward infection, both within hospitals and back out into the community. So we're always trying to strike that balance. What we have been doing via the Gold Command and our Chief Nurses Group is we do review that on a rolling basis. Typically every 4 to 5 weeks we take stock, review the situation. What I think is only fair to say, though, is that if we feel that the situation with COVID gets worse, we may have to tighten up those visiting restrictions. So it's not always a one-way street, unfortunately. I think in terms of your third point, I'm probably not the best qualified person to answer that. I know the system around allocation of people who are homeless to GPs will continue, but I'm unable to answer the question in terms of the bed for rough sleepers that you referred to in your question. But possibly colleagues who are also on the call may be able to answer that one for you.
Yeah, it's Warren. I can say a little bit about that. So we're in an active process now through the combined authority with government on extending the physical provision and trying to clarify where that will be, so that we can maintain and sustain some of that support that came through the Everyone In programme as part of the response. And at the same time, the point that you'd identified, Councillor, about the coordination of provision of a range of healthcare services, both in terms of general practice and primary care and mental health and substance misuse services. We were able to, I think, learn a lot about what good healthcare provision for a homeless and rough sleeping population is, based on I think some really good experience of people that have been doing this for a number of years. And what we're trying to do now is work across colleagues in the health and care system to say, actually, what would a sustainable model of homeless healthcare look like for our population, not only to sleeping, but for either single people or families in temporary accommodation. So I think there will be both ongoing work and some degree of legacy from that work as well.
If I can add as well, regarding the second point you made around hospital visiting, unfortunately, because of the current situation in Bolton and the very high levels of infection rate, we in the hospital have had to reduce and restrict visiting prior to what it was like in the peak of the pandemic, along with our colleagues in social care who've had to restrict visiting to a number of the care home facilities too. So we have got to play our part in trying to maintain and reduce the virus load.
Well, thanks very much. I do appreciate that. It was just how long it was anticipated to go on, but I realise it's open-ended. And the homeless question was related to the topic in the minutes, which I didn't raise under minutes because I knew it would be coming up later. Thank you very much.
I'm sorry, it's Tracy Bell. I don't know if the homeless topic was answered because I had to dial out and back in.
Have you anything else to add then, Tracy? They were saying that they were hoping to develop a sustainable model.
We are, even before COVID, we've done a lot of work in this area to ensure that homeless were able to be registered. Now there's a couple of things that we've accelerated. Obviously, we've ensured that during COVID, and what we need to do, as you say, is maintain that. There are some other digital methodologies that we're also using, so we can register without being in person. That can be done through health kiosks across the localities and through other reach into homeless hostels, so that happens directly. Of course, we want to enable this. What we want to do is also enable, because homeless have lots of different journeys, they appear in different places, to enable a quick and agile change of registration and actually a care for homeless residents, even if they're not registered. That will be the next stage that we're hoping to enable as they appear in different localities and shouldn't be restricted by their registration in part.
Thank you very much.
Thank you. Margaret.
Thank you, Chairman.
Cunningham was waiting.
Can I just echo Councillor Smith? I think the logistics of this response has been absolutely fantastic and really impressive. And I think officers are to be congratulated on what is, really strong partnership working. But I've got two questions. One for Dr. Val first. It's about residents in care homes and vulnerable and disabled people accessing GP services. I think they're finding the triage system a bit difficult to cope with. And the other one is for Bernie Enright. lots of daycare centres have been closed across the region for understandable reasons, but that's put a tremendous burden on people who are caring for their loved ones at home, whether they're disabled or elderly. So just what support has been available to them? I'm aware they've been receiving phone calls on a weekly basis, but dealing with somebody with an autistic youngster is really, really difficult. So what practical support have they had? Thank you.
Shall I answer first? It's Tracy Vell. Just to say that digitising suddenly in terms of the pandemic has given us as GPs some cause for concern, and we are looking really closely at digital outcomes, at the inequalities that presents within our population. So not just learning disabilities, those who are in difficulty getting through on digital devices or telephones. We're in the phase of recovery now, and really at these outcomes to direct more active case finding and allow different channels open to practices. I will say that telephone has always been enabled, as well as the other methodologies for accessing practices, and also in some email and texting. So we are trying to look at the inequalities that come from a digitised service, and we probably think a little bit differently to the Health Secretary, that we shouldn't be 100% digital. We should actually be providing a full range of services. And now going into recovery, we need to target areas that have found access really difficult, but without losing some of the digital methodology that enables quick access for certain groups. So if we can do that, it gives us more capacity to actually reach out to the citizens in the most need, especially around access, but also in long-term care conditions as well.
Thank you.
Thank you. Councillor Cunningham.
It's Bernie. Councillor Morris's query, Chair. Is that okay?
About the daycare centres, John.
Yeah. Is that okay? Shall I carry on?
Please.
Okay, Councillor Morris, thank you. Absolutely recognise the question, and we all share your concern about having to close day centres, short breaks units when people are vulnerable, and families often need a much needed break as well. It was after much risk assessment at the start of COVID. I can talk about Manchester, and I've had conversations with my fellow DASs across the other 9 localities. We had initially thought we'd keep one centre open, but with the concerns around social distancing and shielding people who are vulnerable, it proved not to be possible. We did keep, in other areas did the same, emergency respite, a small amount of it open across GM in a number of areas. And we're stepping back up that respite and day centres now, but obviously our numbers are greatly reduced because of the social distancing regulations. You're right, most areas have kept in contact with people who are vulnerable, and if necessary, emergency respite, which isn't ideal, has been arranged, but it has been a really challenging time, both for vulnerable people and for those who support them, to keep safe. We are looking all across the 10 localities now at stepping back up those services, obviously with reduced numbers and social distancing.
Yeah, I'm really concerned about the health and well-being of carers, Bernie, because it is a tremendous burden. Otherwise, they wouldn't have been assessed as needing help, but it is a real concern.
Yeah, I absolutely agree, and it's what can we do to step back services up safely as soon as we can now, which I know I'm in the chat with the 10 DASs, and I know we're all comparing notes about setting back services up safely across the 10 localities now, Councillor Morris. So I would have thought you'll be able to get some updates locally, but obviously it's absolutely essential, and we shared the concern in terms of the isolation as well, and just having to stay indoors at home and no change of environment.
Okay, thank you, Chairman.
Thank you. Councillor Cunningham.
Thank you, Chair. Well, there's been a lot of ground covered there on many topics. Perhaps I could just use a real incident to sort of highlight my concerns around the A&E appointment system and 111. Obviously, I can only talk about something that I know happened in Bolton, and I know this in detail. In the last 2 weeks, we had a classic example of where we perhaps have to have a little bit of a rethink about this. A patient presenting with severe conditions of stomach pain and vomiting and diarrhea goes through to the GP triage service and gets a call back from ultimately from an advanced practitioner after really being ill for over a day and through the night. Then gets a prescription to be picked up for nausea and something for stomach cramps. Goes through another really bad day and a really bad night until Wednesday morning, when finally have to take them into A&E and say there's something really wrong here. Okay, you go through all the triage stuff and ultimately questioned gastroenteritis, query appendicitis, but not likely. And then went through from 11 AM till 8 PM that night until a consultant appeared on the ward and said this patient needs a really urgent scan. Turned out to have a gangrenous ruptured appendix, so really in the danger zone here in terms of septicemia and peritonitis, etc., and possible death, because there seems to be some gap in the provision there, and it's not through any individual want, or it's just trying to follow a system where there doesn't seem to be the hands-on initially or face-to-face initial consultation that would perhaps throw up things that would throw up other warning signs and start alarm bells ringing that would move this process through faster. And so when we talk about triaging people through 111, which is basically somebody reading off a script and ticking boxes, and we've got algorithms there, but we all know with a computer, and we mustn't forget this, you put rubbish in, you get rubbish out. It's not the perfect scenario, and I was really happy to hear Dr. Tracy Velle say earlier, we need to keep the digital provision as part of the system, not ultimately, as we come out of this, as the replacement. But I am worried that we are missing things, and we'll be missing this in many practices and within the hospitals itself. So I think it's something we need to keep under, I presume, constant review, and maybe some of the other contributors here might have some ideas, particularly going back to Gold Command and Deputy Gold Command with Fiona and Silas, as to how they could assess this, perhaps process the data and look at perhaps near events or near misses or whatever we call them, and perhaps drill down to find out why we're getting these and if there is an actual improvement we could make in this procedure. Thank you very much.
Can I suggest that via Lindsay you send an email to be forwarded to Fiona Noden at Bolton, and then she can maybe answer your questions more directly about the case you mentioned, because I can't really allow it to continue being discussed here. Your general question, yes, and I'm sure that people are going to answer that now. Thank you.
Thanks, Chair. Perhaps if I could come in at this point, I think it's a good point that the councillor's made. I think all healthcare systems will, on occasion, not work as we wish them to work. I think the critical thing, though, here is making sure, and the councillor alluded to it, is that we've got systems in process to actually pick up, audit and learn where things are going wrong, basically. So one of the things that we're having in place is a system of critical incident reporting that will basically allow a rapid review of a case in point, but also what it also allows us to do is to pick up if any themes or trends are emerging as well. I think the final thing which we're trying to do is strike a balance between recognising the urgency of the situation and moving quickly, but also trying to make sure that we don't move so quickly that we start baking in some structural problems, and hence that's why we're still taking the decision that we will do a phased approach over a number of months rather than doing a big bang approach all at once. So hopefully that will give some idea to the council as to our approach, and as you've already suggested, Chair, I'm sure the specifics around the individual at Bolton will be picked up outside of this meeting.
Thank you. Right, Councillor Akhtar. Councillor Akhtar.
You're on mute, Councillor Akhtar. You just need to unmute your mic.
Sorry. Thank you, Chair. Similar to previous speakers, I'd like to echo the comprehensive work that the officers have done on the excellent work that's been carried out. But I don't know, my question is if this is the right time to raise it. It's just basically around the actual support available for people who've suffered COVID, you know, if they've had long-term symptoms, and what kind of support is available for those individuals.
Yeah, so perhaps if I can come back here, Chairman, if that's okay. So there's a couple of things that we're putting into place and have put into place. So one is basically building on the lessons from the Manchester Arena attack, where we established a resilience hub for those people, victims of the attack. We're doing the same thing for those patients who have been through long-term treatment, in particular those patients who have been through intensive care and been hospitalised for several weeks, to give them that ongoing support and treatment as well. So I think that does go some way towards addressing the issue that you've raised. Similarly, what also we're seeing now within individual hospitals are clinics being established for members of staff who again have been affected by COVID. And I think it's fair to say that there's an emerging body of evidence. It's still early days. You can imagine the science is still evolving. That does suggest that for some patients, COVID actually does have a number of long-term implications, whether that be physical or psychological. And I think as we learn more about the science and the medical science with COVID, no doubt our services will develop further. Thank you.
For that, but my sorry, I didn't make it clear, but it was mainly for individuals who haven't been hospitalised. I personally suffered. Well, I'm assuming that I suffered from COVID. I was ill for about 10 weeks at I was ill from beginning of April, and when I was tested 4 or 5 weeks later, it was negative because the tests weren't freely available. So it was just around people who weren't hospitalised. Sorry about that.
No, that's quite okay. So I think at the moment we're focusing our resource on those patients who've been most seriously affected, which is really sort of a prioritisation exercise that we've gone through. I think as we go more into that phase 3 that we've talked about sort of the restoration of normal services, no doubt at that point some of these wider questions that you've raised, Council, will need to be assessed. But at the moment, there's no firm plans for those patients who would be not hospitalised about what ongoing support other than normal primary care would have in place.
Thank you, Warren.
Thank you, Chair. So I'm conscious we're only in the last few minutes now, so I suggest that we do a very kind of quick run through from Sandy on a couple of minutes on mental health considerations, and then I can offer some concluding thoughts on recovery, if that's okay.
Okay, so just because of time and things, I'll just focus on a few key bits, if I'm honest, and just building on Silas's point that we are picking up bits around, possibly around the sticky blood and other bits and the neurological bits and the bits around post-viral type stuff. So we're starting to think about how we provide that support in from an emotional and mental health angle, but we'll also need to think about that in terms of the combined bits that we know around ME into CVS and stuff around that, so we will pick that up. I think the key bit, and trying to move past the slides really, is that the mental health and emotional support that we've needed to put in have only been possible because everyone has combined together, and that includes across our trusts, social care and our VCSE communities. And I think that's really important in terms of the way we've tried to organise support generally for everyone. So those 24/7 helplines is for anyone can ring in, known or unknown patients, and that's been stepped up, and people have been. So about at least 25% to 50% of the calls we've been receiving through that are people we've never known before. So they sort of worked. The resilience hubs, again, that Silas and others mentioned, we set up after the Arena attack. I think we've extended that and supported and targeted that initially, particularly at those key workers, because we needed to keep them going, very much like the bit when we used to be allowed on airplanes and bits properly, whereby you'd be told early on, put the mask on yourself, then on your child, because you've got to keep the system going, and therefore you needed to keep the caregivers going. So we targeted that support, particularly at our hospital staff, our key workers in social care settings, our GPs, primary care, and our blue light services. So that's worked well, and we're now starting to extend that for those folk who have been more damaged or more hurt through that experience around sort of the death and the bereavement support that we put in place. The digital offer we've made available across GM, across the board, and that's being pretty well used now for all children, adults, and they've been able to text and or other offers. On top of that, though, what we've done is we've also put in support for 95% of the communities using different languages, because we've done multiple language offers of physical hand materials, because we know there's an issue around digital exclusion and poverty and stuff. So we put those bits in, as well as practically trying to guide people away from A&E. That was the message I had to give very clearly. We had to give the space for folk. Now we know that's had a knock on, I think an earlier point there, for some folk around people with learning disabilities and autism. We know that that's had a negative effect in terms of those carers being able to translate. But again, we're doing joint work with the hospitals trying to work that one through. I think that last bit that there is, we've actually put hard cash and real extra services around a range of our communities, and that's again proving quite effective, working in with the Jewish community, the Chinese communities, Persian, across the board, as well as autistic communities. We've offered extra helplines and stuff. So there's a range of services we've put in place that have been across our trust, NHS, social care, and our VCSC together. So if you keep going in terms of the bits around that, I think the key bit is what we're facing now as we go forward. One of the bits I think that was predicted was that our mental health surge would come a bit after, if I'm honest, the physical health surge that would get really pushed heavily around that side of things. What we've actually experienced, though, I have to say, is a significant rise in more acute patient presentations and more of them. So if I look at Wigan, double the number of cases are currently being looked after, say, through our crisis teams. We're having real struggles just coping with the number of people that we also need to hospitalise. So we're struggling around the bedside of things. So while we've been really effective around, I guess, the physical health, the mental health bit has come through more rapidly than we expected. We have been predicting more support, more demands from the school side as they opened, but we had a previous schools programme that we've basically building on. And I guess that's the key bits of these slides. We're trying to give the message that we're there, we've got a plan. There is some major issues around capacity in GM around our baseline offer is probably not as big as it needs to be, and we're trying to negotiate extending that where possible. Our problem's going to be, very simply, is that there is lots that we're going to need to do, but we are going to have to prioritise out of this which folk we end up having to support through this. I think, Warren, that might help just get you right into the next bit, because I know you need to catch up on time.
Thanks, Andy. And in the interest of time, and just to offer some kind of concluding thoughts, I won't use the slides as such, but I will call out 4 kind of key issues and considerations that will guide most of our work through the recovery phase that Silas had touched on before. And these are in no particular order of priority, because I think they each matter, and they'll each have to be done and considered at the same time. So the first is around the restoration of core services, and there is an immense amount of work underway at the moment on recognising the extent to which that disruption of care, planned and ongoing, has meant that we've really got to start reintroducing those services and working our way through the list that will have built up through the period of lockdown and disrupted care, and that will be possibly one of the key areas of focus for the hospital cell and the collaboration across the system over the coming months. Second is the recognition that COVID didn't affect everybody equally, and it rooted out and exposed entrenched health inequalities and wider inequalities across our society. And if we are both to build back better, as the phrase has it, but also to protect ourselves from the worst effects of any second peak or surge of COVID, then we have to focus on where that resilience is lowest in different communities, and define a health inequalities focus for our recovery work. The third issue is around where that resilience actually affects key parts of our system, and Bernie identified it before when she described the relative fragility of the adult social care market, and this is something that we've identified for a number of years, but seen really exposed through the COVID pandemic, around the need for sustainable finance and development of the adult social care market as part of our health and care system. And there will be a significant amount of work underway in Greater Manchester, including representations and negotiations with government on how we can support that in future. And then the fourth thing, which has also been referenced, is around the opportunity that this presents us with as we think about rebuilding our system looking forward, recognising the extent to which we have operated and responded in a deeply integrated and cooperative way, from the organisation of support at the neighbourhood level right up to what Silas and colleagues have described in terms of the system level coordination that's existed across the whole of Greater Manchester, and for us to have one eye on where, out of necessity, we innovated in the way that services are provided and accessed, and then consider the extent to which those innovations should become part of our mainstream way of working. So I'd offer those as kind of concluding thoughts, Chair, in as much recognising that this is the first restart of this scrutiny committee for the municipal year, and it'll be thinking about some of the key issues that it might want to touch on over the course of its work in the year ahead. So we're hoping that the content of the paper and the slides might also support the committee's consideration in terms of its future work programme as well. And I'll leave it there. I think you're still on mute, Chair.
John, I think you're on mute.
You're back on mute, Councillor O'Brien. You just need to press your microphone. That's it.
Thank you. For the third time, my apologies. Members, if you've any questions, I see Councillor Dutton's waiting. So if you come in now, Ray, please.
It's just a comment to thank all officers in the NHS and everyone concerned in the safety of our constituents. I think this is the best meeting I've sat in since COVID-19 hit us. And I'd just like to thank everyone, including yourself, Chair, for the way this meeting's been organised. And I welcome this committee coming back into force. And thank you.
Hear, hear.
Right, members. The next item on the agenda is the work programme. But as Warren has just indicated, there's a lot to absorb from these slides. And Lindsay and Joanne are going to get them out to all the members of the committee. But really, as this is a very live, very dynamic situation with COVID, this is going to be going on. So I would say that we plan basically around dealing with progress or current events within the COVID at the next meeting, and we move it forward on that manner. Unless anybody's got an objection, can we accept that, please?
Aye.
Thank you. Right, several of you have thanked officers, presenters, etc. Ray summed it up. This meeting has been very positive. At no point has anybody been pointing fingers and being critical of the way things have been done. Over the last 6 months, I've been approached on many occasions to actually scrutinise the way COVID's being dealt with in GM. Predominantly, this is a national process, and our public health people and our NHS staff in general have been responding to their directions suitable for their localities. Hindsight's a wonderful thing. There's always things we could have done differently, and I'm sure in long years in the future we will look at that. However, now I think we should all be grateful for the work being put in by frontline staff, by management, and by elected members. I thank you all for what you've done, and I thank you for participation today in this meeting. The next meeting is on the 11th of November at 10 o'clock. If we can sign in by 9:30, that way we might iron out any little bits, and we've done very well with the technology today, very well indeed. Thank you very much, members.